Thank you all for coming back. So this session is a celebration of the things that we, and this is the we meaning you, have done with the things that the Commission, the tools that we gave you and what we'd asked you to do. So we have asked representatives from DHBs to come and talk today about the things that they've managed to achieve in the work streams from the programme so far. We're kind of realising now I've done this the wrong way around, because tomorrow I'm talking about what we've done, and these are each DHB, or what the plan was, and here you are telling us what you've done. So I won't need to give my talk tomorrow because you already know what you've all done. So we have 5 speakers, 15 minutes from each DHB. It's very fluid. You can ask questions at the end. If you don't want to ask questions and we still have time at the end, we might bring you all people up here. We have microphones and a panel, and then you can ask questions of the quality improvement people who've done these programs in our own DHB about their work. The point of this is to celebrate what people have done and all the hard work you've put in, but also as a pointer to, if you are within your own DHB struggling with particular issues of the programme, to ask us as a group, including myself and members of the Commission and the people who are doing this, so we can all learn from each other. So I'll initially begin by saying what the work streams are. For those of you who are unfamiliar, there are 3 work streams as part of the National Deteriorating Patient Programme. The first one was to standardise the early warning score and the vital signs chart across the entire country, and it seems like we're going to be able to do that across all public and private hospitals. Probably by March to April next year we'll have 100%. There's no other programme, I think, other than Ireland that's managed to do this internationally. In the UK, although they have a national early warning score, they've still only got about a 50% compliance, so that's something we should be very proud of, not just because we're a smaller country, but because people have really run with this, for which I'm very grateful. The second work stream is Kororo Mai, which is Talk to Me, which is a patient-based family far-now escalation program, which we'll be hearing more about later. And the third work stream is a National Shared Goals of Care program, which is in its early gestation but progressing well. So I would like to invite the 5 speakers. The first speaker is Jen Haslock, who's a Quality Improvement Advisor from Nelson Marlborough DHB, to tell us about the work that they've been doing there.
We know that the earlier we recognise and respond to patient deterioration, the better the patient outcomes are. Effectiveness in these processes hinges on many things, and today I'm going to share with you some of our learnings from setting up a regional hospital critical care outreach team as part of our recognition and response program. If I can get the thing to go. Hey, my name is Jen Haslock, and I'm an improvement advisor at Nelson Marlborough Health. No, forward. Excuse me. Our DHB serves a population of approximately 148,000 people across the top of the South Island. While the region is lower than the national average in deprivation, we have a significantly older population. We are a centre of heavy labour industries, fishing, forestry, farming and fruit, all of which impact on our trauma statistics. We have a 7-bed intensive and coronary care unit in Nelson and a 5-bed acute assessment unit in Wairoa. Nelson ICU has the capacity to run 2 ventilators and has the flexibility to run a third if pushed. The unit takes patients from smaller centres and transfers spinal injuries, burns, cardiac bypass, NICU and PICU patients to tertiary centres in Wellington and Christchurch, a 30 to 45 minute flight away. There is no separate coronary care facility, so complex electives including post-cardiac interventions are managed in the unit. The unit is staffed with 5 nurses per shift and has specialist medical coverage between 8 a.m. and 6 p.m. 7 days a week. Outside these hours, patients are managed by various anaesthetists, surgeons and physicians. This model of medical coverage has significant implications for the continuity of patient care and the management of patient flow through the unit. The hospital has 191 beds and predominantly manual systems. We have paper-based auditing and emergency activation systems which work on a combination of paging and teleops phone trees. We are in the process of transitioning from paper to electronic vital signs and medical records management. In setting up the critical care outreach service, we had to get our ducks in a row. We identified these ducks as nurses, doctors, ICU capacity, teleoperations, hospital capacity and ward activation. We began by providing education and support to 12 nurses who were identified as experienced and confident enough in their own critical care practice to troubleshoot deterioration, support ward staff and advocate for additional escalation as needed. These nurses stepped forward to take this on as an additional role. The service is not protected in the sense that it is expected to run within the existing FTE of the unit, and because of this, the service was set up on an ad hoc basis. So, our outreach team started getting out there and supporting staff, following up on patients of concern and responding to early warning scores that were just starting to creep up. What we found was when the outreach was in full swing, so our top of the mark there, our emergency rate dropped right off. So this is adult emergencies, and that one that we had was an adult emergency that came from the emergency department, so whatever it was pretty major. So what we found was that this wasn't actually isolated to Nelson either. Wairau's pattern was actually really similar. Looking closer on a day-by-day basis, we saw frequently that when outreach wasn't active for whatever reason, so the lines were flat, that our adult emergency calls and rapid response team calls occurred. We've also started to see an early warning score shift. So as nurses have started to feel more comfortable calling outreach, they've started to do so more increasingly for patients with lower early warning scores, just because they are concerned. So you can see here that back in April, we were still seeing escalations with early warning scores in that 6 to 9 range group. But if you fast forward to November, we haven't had an early warning score for anything over a 4. One of the challenges that has come out of this has to do with our manual auditing systems. 65 of the total 269 outreach activations were done so based on nurse concern, when the person's early warning score was still in that 1 to 5 range. But it's unclear, because of our manual systems, whether these patients had received early warning score modifications and that the nurse just bypassed this number because he or she was concerned and had a bad feeling. The biggest challenge that we have is that our entire system is balanced on a knife edge. It's really, really dependent on all these ducks lining up. So let's have a look at our nursing duck. In July, there was a dramatic drop in outreach contacts, and there are a number of possible reasons for this. In July, the nurses' strike and near strike reduced elective surgery flow, which may have resulted in a drop in demand for the outreach service. Also, at the end of July, as part of the hospital winter plan, a medical admission and planning unit was piloted. This new unit was staffed by existing nursing staff, including 3 outreach nurses, therefore reducing the outreach response capacity by 25%. On the other hand, if you shift nurses with outreach level skills and experience into a general environment, this also may have prevented patient deterioration at the outset, therefore reducing outreach demand. What we do know is that we not only have to have enough nurses with the knowledge, skills, confidence and experience to staff an outreach service for 21 shifts a week, but these nurses also have to be able to leave the unit, which is dependent on the acuity and the skill mix that's sitting there. So, Alex, take it away. So, we need to have a look at our medical support duck. Nurses... We know that nurses have been empowered to escalate, but the same doesn't necessarily hold true for our doctors. After hours, we have a medical registrar who covers the entire hospital and is the most senior person outside the emergency department. Encouraging our doctors to escalate after hours requires a culture shift and is challenging. As there isn't 24/7 ICU medical coverage, having to escalate to someone knowing that they're probably asleep creates a significant reluctance to call. While as an organisation we aspire to have just culture, evidence suggests we just don't always achieve this. We recently had a case where a nurse accidentally activated a trauma team call instead of an adult emergency call. Not only was the nurse made to feel diminished by the comments, eye-rolling and behaviour of some of the people who attended, but the teleops person was also dressed down as people started to look for a scapegoat. This behaviour has a ripple effect, so as people observe the response to the mistake, it just concretes their reluctance to call in case they get it wrong. A culture shift is required. But change of this nature is highly complex, takes time, and is a little bit like paddling the Titanic. Having a single decision maker for the unit could potentially address this issue, as medical staff would have a person to escalate to that's not only awake, therefore reducing the guilt around waking people up, but who has the knowledge and skills to manage a critically unwell person, as well as having an overview of what's actually happening in the unit should patient movement need to occur. So, our medical duck. Alex, take it away. Our ICU capacity duck. Significant pressure to meet hospital elective surgery targets means that frequently our unit is running at 80 to 100% capacity. Staffing to ANZAC's guidelines means that if you have 2 ventilators, you have 3 nurses to manage the remaining 5 patients. The 12 telemetry, coordinate the unit flow, coordinate flights after hours, respond to emergency calls, and staff the outreach team. Pretty big job, eh? On top of this is the skill mix in the unit, so the ratio of junior to senior staff has to be able to manage what's happening in the unit before even consideration can be given to outreach. So getting a 3rd ventilator would pose significant challenges. It also means the decision regarding outreach availability is determined on a shift-by-shift basis, making the continuity of response wildly variable. How many times would it take for a person to call only to be told there's nobody there to go and support you before they actually stop calling? A staff feedback survey identified this as a risk, with people saying it's great when they're available, but it's frustrating and time-wasting when they're not. This is a huge problem because it undermines the ward-based clinicians' response and confidence in the outreach's ability to respond when needed. So, Alex? Boom! Let's look at the teleops duck. We have a manual teleops system. While outreach is a direct phone line, additional emergency escalation is run on a paging and phone tree system. The teleops person takes a call, writes the time and date and location on an emergency form. They then activate the Jira Suite page or call the appropriate people from a phone list. After this, they scan that form to us so we can put it into an Excel spreadsheet. There is no method for the teleops people to determine whether a pager has been answered, which has been problematic with some events where the appropriate people haven't even turned up to the emergency for whatever reason. So, come on, Alex. The hospital capacity duck. When our emergency department is stretched to capacity, there's strong temptation to modify early warning scores in order to move a person out of the department to prevent them from breaching. This has resulted in people quietly deteriorating on the ward without triggering an appropriate response, and also dampening a nurse at the bedside's confidence in making a call of concern. For example, the doctor clearly isn't concerned that the patient's blood pressure is 90, so I probably shouldn't be either. Outreach has been able to counter this to some extent, as shown in the number of nurses who are calling because they're concerned, rather than waiting until that person's early warning score hits 6. Likewise, when the rest of the hospital is full, there is temptation to use outreach staff inappropriately. We have had cases where the outreach team have been pulled away from ICU patients to cover ward staff meal breaks. This diminishes the goodwill of the staff, remembering that we're relying on these outreach nurses to volunteer for this additional role. So we can see that there's significant risk to the continuity of the service if team members begin to feel that they're being taken advantage of. Go on, kill it. Go, Alex, come on.
Bye.
Fabulous. And last but not least, our ward activation duck. Initially, when outreach was set up, the time spent on the ward wasn't being logged in trend care. So in the system, it looked like the ward was in significant negative variance, while the ICU staff really weren't doing much. We asked the team to start logging their outreach time in trend care, and what we found was that it was actually pushback from the ward staff, and there was a reluctance to call outreach because the time that they were logging in trend care was actually making the overall situation on the ward look less busy. So, come on. Right. So, from all this, we know there's a lot of factors that go into ensuring outreach can run, and a huge number of obstacles and challenges that can easily derail our system. Fortunately for the patients at Nelson Marlborough Health, the ducts have managed to align 269 times since the start of the service in March this year. This reflects the dedicated and truly heroic efforts of our team. Of the 269 patients escalated to outreach, only 6 ended up being admitted to ICU, all of whom had an early warning score of in that 8 to 9 range. There were an additional 38 patients escalated to outreach with an early warning score of 6 or more who were subsequently stabilised and didn't end up going to ICU. So what does this mean for our outreach team in the future? We need to continue to support outreach staff with clear processes, education and advocating for protected outreach FTE. We must also advocate for full-time single decision-making in our unit. We must address the issues around modification and capture the relationship between this and the escalation to outreach. This will hopefully become more visible as we move towards electronic systems, which have the ability to highlight issues and close the loop. We need to strive for a just culture, and above all, we must just keep paddling and moving forward. Thank you.